To Chapter 11. In this chapter, we are going to be discussing the core body. This mostly includes the spine, abdominal section. The spine consists of cervical, thoracic, lumbar, sacral, and coccygeal vertebrae. As a whole, the spine gives the head and body support, maintains the body shape, provides movement, and protects the spinal cord. First, we're going to talk about posture. When we look at spinal injuries, especially chronic injuries, it is imperative to evaluate the athlete's posture. Posture is the positioning of and arrangement of body parts in relation to each other. When an athlete has incorrect posture, there is a greater chance that stresses will adversely affect bony and soft tissue structures. The stress on the body due to incorrect posture can cause this chronic injury. Most times, when we have this incorrect posture for a long period of time, we consider that the onset of the injury is insidious or happening over a long period of time without having a definitive start and end point. Poor posture can cause chronic injury not only to the spine but also to the extremities. Most often, the lower extremity is affected by incorrect posture. Therefore, we need to evaluate the athlete's posture to determine if the faulty posture is the cause of the athlete's lower extremity problem. If the faulty posture is causing the chronic injury, then the athlete's posture needs to be corrected. Incorrect posture can be genetic and evident at birth. It can also result from incorrect body movements and positioning after injury. The athlete may utilize poor sitting and standing habits, and as he or she ages, their posture may be affected. When we see that the person or an athlete has poor posture, one of the first things that we need to do is evaluate their posture. We must first recognize what is considered normal posture. When we look at normal posture, we are looking at this in relation to the athlete from the anterior, posterior, and lateral views. When we examine the athlete in the anterior or posterior view, we need to visualize a line running down the athlete in a sagittal plane. Look at this picture. We can see that this picture has already drawn a red line through the midsection of the athlete. You can see that sagittal line which breaks the athlete into left and right halves in figure 1. This is what is referred to as a plumb line. A plumb line can assist you in creating these sagittal planes. This is really just a string that it's suspended from the ceiling and attached to a small weight, so it is hanging there so we can have the athlete stand behind it. To examine the athlete's anterior structures, as we see in the left-hand side of this picture, we need to have him or her stand behind the plumb line facing you. In this position, the athlete's body is divided into two equal halves. The plumb line, or this sagittal line, bisects the athlete's nose, sternum, and umbilicus, and is lined up midway or should be lined up midway between the feet. We need to also observe where the athlete's eyes, ears, acromioclavicular joints, antecubital fossas at the elbows, iliac crest, patellas, medial longitudinal arches of the feet, and the great toes are. We can really determine what is and what may be causing an injury by comparing bilaterally with matching part on the other side. The posterior structures. For the posterior structures, the athlete must stand with his back to the plumb line, bisecting again his body into left and right sides. As you look at the plumb line relative to a spine, the spine should be straight. The spinous processes for each vertebrae should be in line with the plumb line. And we need to also look into a couple other things as we did on the anterior side, such as the height of the shoulders, olecranon processes, scapula, iliac crest, popliteal fossa, and the calcaneus. We need to make sure that these are equal and equivalent on both sides. If we do see something different, then this may be the cause of the injury. Lastly, the middle part of this picture indicates the lateral view. We need to have the athlete stand to the side of the plumb line. The plumb line should run through the middle of the ear's auditory meatus, the acromion process, the greater trochanter, slightly posterior to the patella, and in front of the lateral malleolus. After we do complete a posture analysis, the postural deviations can be the cause, and we can identify the cause of acute and chronic injuries to the body. Next, we're going to break down the spine into the cervical, thoracic, and lumbar spine areas and talk about injuries in each of these sections. First, we're going to look at the cervical spine. The cervical spine consists of 7 vertebrae, 8 pairs of cranial nerves, and it starts at the base of the skull, travels through the cervical vertebrae, and continues down to the sacrum. The first 2 vertebrae at the base of the skull are the atlas and axis. These cannot be palpated because of the musculature, but they provide the head movement in flexion, extension, and rotation movements. Overall, the cervical spine has a lordotic curve, and we know that there are many injuries injuries at the cervical spine are very traumatic and can be very serious and life-threatening because of this curvature as well as the anatomy in this area. First and foremost, we're going to look at fractures and dislocations. Cervical fractures and dislocations are amongst the most serious and damaging injuries to the body. When we look at these types of injuries, dislocations can occur between any 2 vertebrae. Cervical fractures and dislocations that occur at the atlas and axis can be life-threatening if the spinal cord is also severed. Remember, these are bones that we cannot palpate, and they're the first 2 that are at the base of the skull. If this area is injured, the individual can become a quadriplegic, meaning that if we have a fracture or dislocation of the atlas or axis, pushing on the spinal cord or having the spinal cord severed, this will affect the movement of that individual. When we look at the mechanism of injury for fractures and dislocations, typically we see a direct impact to the top of the head when the neck is approximately flexed into 30 degrees. When the neck is in this slight degree of flexion at 30 degrees, it straightens out the lordotic curve of the cervical spine. This straightened spine facilitates force transmission, which basically crushes the vertebrae into one another. We can see here that this is a picture of a fracture of a cervical vertebrae on the left-hand side. On the right-hand side, would be a dislocation of a cervical vertebrae. Now, the other mechanism that we can have, other than the direct head impact, we can also have a forceful flexion extension type of mechanism that snaps the neck. This is what we refer to as whiplash. When we look at signs and symptoms, typically what we see is bony spinal pain, especially with palpation, inability and unwillingness to move the head, maybe they're scared or they are in a lot of pain, a loss of function, and or sensation through the arms or legs. So we may not be able to move our arms and legs depending on where this injury occurs. Also, the athlete may go into shock depending on how traumatic the situation is. For treatment and immediate care, our first priority is to see if the athlete is conscious. We also need to check ABCs, airway, breathing, and circulation. And due to it being at the cervical spine, we need to maintain inline cervical spine stabilization, tell the athlete not to move, and call 911 immediately. As we wait for 911 to be called, we need to determine the extent of the athlete's consciousness, continue to assess ABCs, and determine if the athlete is feeling his or her arms and legs. When EMS arrives, typically what will happen is that the athlete will be spine boarded and transported to the hospital. For prevention, we need to make sure the athlete knows proper athletic activity techniques such as tackling in football or rugby. We also need to have the athlete abide by activity rules meaning that there are rules against spearing in football, and that is to protect football athletes from cervical fractures and dislocations. We also must have individuals wear seatbelts in the car so we don't get that whiplash type of mechanism of injury. For spinal cord and nerve injuries, remember that these can occur if we do have a fracture or dislocation, and these can be traumatic, such as with a severed or contused spinal cord, but it can also be chronic, such as a disc, a spinal disc compressing on the spine, and or a nerve root. So when we look at the mechanism for spinal cord and nerve injuries, they can occur due to a direct blow on the top of the head. This would be secondary to a cervical spine fracture or dislocation. The athlete could get the same mechanism of impact from falling onto the head. The spinal cord can also be contused and swell and put pressure onto the spinal cord, as well as it can occur from the athlete having small vertebral foramen, which is where the spinal cord travels through, and that could cause compression onto the spinal cord. Signs and symptoms that we see. Remember, this could be life-threatening, especially if it occurs at cervical vertebrae 1 or 2, which is, remember, the atlas or axis, because at this juncture of the cervical spine, it can affect breathing. More often, these types of injuries are more often limb-threatening, and it may not affect their breathing, but it may affect their limb movement. So what we need to see, first and foremost, we still need to check the athlete for consciousness, ABCs, but we also have to make sure of any paralysis into the extremities depending on the level of the spinal cord injury, as well as pain. They may have incontinence and not being able to control their bladder, and they may have muscle spasm in the area, and this is typically in order to protect the injured area. The muscles kind of contract in order to protect the area around. For treatment, if it's acute, we need to call 911. Medical, and this is what we would refer to as a medical emergency. Maintain normal inline stabilization as we would with a cervical fracture or dislocation. Monitor our ABCs and make sure to tell the athlete to remain still. Once they're referred, they're kind of out of our hands, but typically what happens is that they're given some medication to relieve the swelling, and they may have to undergo surgery. If it's more of a chronic type of spinal cord injury, we need to complete a secondary survey, determine the severity, irritability, nature, and stage of the injury. We may inform them to take some non-steroidal anti-inflammatories, but really what we want to do is refer them to a physician, and the physician will then inform them of what they need to do. Prevention, we need to make sure we're performing the skills properly and abide by activity rules. This is a picture of the spearing type of tackling. So you can see the incorrect picture on the right with the head down, which places that cervical spine into more of a straightened position compared to that lordotic curve on the left-hand side of that picture. Next, we have a herniated disc. And our disc that we have in between each vertebrae is made up of the annulus fibrosus and the nucleus pulposus. And the annulus fibrosus is that outer, harder, more thick area of the hernia or of the disc. And the inside, the nucleus pulposus, is really like a jelly-like soft substance. And if you think of a jelly-filled donut, we have that outside of the donut, which is that annulus fibrosus, and which is inside the jelly is our nucleus pulposus. And if we have injuries to the disc and it starts to herniate, think of just squeezing that jelly-filled donut and that jelly coming out, and that's what we see with a herniated disc. So for this to occur, we typically see mechanisms of a period of time that's chronic, but these are typically due to not having enough range of motion and placing stress on that area over and over again. Especially over time, these discs, especially the annulus, the nucleus pulposus, loses water content and they start to degenerate from the outside as well. And once we have that outer shell annulus fibrosus start to break down, that jelly-like substance tends to squeeze through more easily. For signs and symptoms of a herniated disc, they may cause pain, loss of function. Typically, they don't have any signs and symptoms until it gets worse. They may have numbness and tingling depending on how much that disc is pressing on the spinal cord, and depending on where that spinal cord is pressing, could have some burning, tingling sensation down the arms and or the legs. For treatment, we need to refer the athlete to a physician so they can rule out any other injuries or conditions. And what the physician will do, they'll prescribe various medications to reduce the swelling in that area and decrease the pain. But after that, person usually undergoes rehabilitation to strengthen the musculature around that body part. For prevention, we need to have good posture, including using proper body mechanics when lifting, pulling, and pushing heavy objects, having strong core musculature, not just the abdominal area, but also the back musculature as well, and maintain a healthy, normal weight so we don't place undue stress onto the spine. Like other parts of the body, we can have sprains and strains to the cervical spine. These tend to occur concurrently or together, and they are often caused by a forceful motion of the neck, such as whiplash, or a forceful hyperextension of the neck followed by immediately forceful hyperflexion. And what we can see this in a car accident, or we can see when an athlete gets tackled violently on the field. Signs and symptoms are very similar to other sprains and strains throughout the body. We have loss of range of motion, stiffness in the area, and this area would be the neck, point tenderness. They may be holding the head very still because of that pain, and they may not want to look around or go through that range of motion. For treatment, if the athlete can't move his or her neck and they're in a lot of pain and it's noticeable to you, we need to refer them to a physician just to get looked at just in case. If not, they still may have some spasm in the cervical spine area. We can apply ice to reduce that spasm. Also take non-steroidal anti-inflammatories to alleviate pain and inflammation. And what we typically see is what they call a Philadelphia collar. This is that soft kind of neck collar that you see that older adults wear to help with stabilization and resting the neck musculature. For prevention, we want to make sure we avoid forceful cervical spine movements, and also make sure we have proper range of motion, adequate muscular strength, and flexibility in the cervical spine area. Acute torticollis, also referred to as Ryeneck, really is a sudden painful neck spasm in the cervical spine area, and it can be caused by bending or twisting the neck, stress, muscular tension, or sleeping in an unusual position for a long period of time. We look at signs and symptoms. They have neck pain, stiffness, and what you can see in that picture, they hold the neck to one side, and this side is opposite to the pain because they don't want to use that musculature on the painful side to contract. For treatment, if they're in severe pain and they're unable to move their head and function, we should summon EMS. We don't know what could also have caused this injury. It may be an underlying injury, such as with the cervical spine. So we need to summon EMS just in case, and then refer them to a physician. If it's just a small bout of acute torticollis where there's just minor pain and they're still able to move it a little bit, what we want to do is massage the area, maybe put a moist heat pack on it to reduce that muscle spasm. For prevention, we want to make sure that we maintain normal alignment of the cervical spine, so normal posture, perform range of motion activities, and neck strengthening activities. So as we move on to the thoracic spine, a lot will look the same, and there's not a lot in the textbook about thoracic spine injuries because they are all the same injuries as we just talked about with the cervical spine. So similar to the cervical spine, we see these same injuries with the same mechanism of injuries and the same symptoms. So we're not going to take a lot of time talking about the thoracic spine. We'll talk about some differences and what the thoracic spine is made up of. So when we look at the thoracic spine, it has 12 thoracic vertebrae, and unlike the cervical spine, the thoracic spine is a kyphotic curve, and it does not have as much mobility as the cervical spine. And this is because of how the vertebrae are configured and how close proximity they are to one another. But like I said, overall, the thoracic spine injuries are the same as cervical spine injuries. When we do look at these injuries, we want to make sure that we care for them the same, and we want to prevent them in a similar manner to cervical spine injuries. So you could read a little bit more about thoracic spine and how those injuries are different, but like I said, you could still get fractures, dislocations, not as much dislocations because of how compact that area is compared to the cervical spine, but you still can have some fractures, but you can also have muscle sprains and strains in the area, and we'll talk about some other rib cage type of injuries later in the chapter. Last but not least, we have this lumbar spine, and when we look at the lumbar spine, we typically see a lot of chronic injuries to the lumbar spine, but the lumbar spine consists of 5 large vertebrae, and just like the cervical spine, the lumbar spine has a lordotic curve and a pretty good amount of range of motion. So if we're looking at the range of motion, we'll look at the cervical spine first, then lumbar, and then the thoracic spine having the least. So we still have a good amount of range of motion, which can cause injuries to this area. And we see that when we look at the lumbar spine, lumbar fractures and dislocations typically occur mainly with high impacts. We don't see this a lot with sports and athletics. We typically see a lot of these injuries in motor vehicle accidents and falling from an unusually high height. We can also have lumbar spinal cord injuries, similar to thoracic and cervical spine. We can also have herniated discs, sprains and strains because of musculature in that area. So those typical things also do occur, but let's look at some different injuries that can occur specifically to the lumbar spine. The first two we're going to look at are spondylolysis and spondylolisthesis. And spondylolysis and spondylolisthesis are both chronic types of injuries that occur over a period of time. Spondylolysis, which is your first injury we're going to look at, is when the lumbar vertebrae has a stress fracture. And typically what we see in this top left picture is that stress fracture in that fifth lumbar vertebrae. The next commonly injured vertebrae is the fourth, so around the fourth or fifth lumbar vertebrae, which is, if you wrap your hands around the top of your hips, that's where you'll get your fourth and fifth vertebrae area. So if you have pain within that area when you wrap your fingers and your thumbs around to your back, it can be caused by spondylolysis or spondylolisthesis. For spondylolisthesis, this occurs when the stress fracture of a spondylolysis completely breaks through the bone, causing the vertebrae to become very unstable, and it can actually start to shift. So the difference between the pictures that you see in this slide is that fracture on the top left is still pretty much in line with the bottom part of the vertebrae. And when you look at the bottom right-hand picture, you can see how it slides forward or anteriorly. So as a result of this unstable vertebrae, the vertebral body begins to slide forward on the surrounding vertebrae. So if we have an L5 that's affected, then L5 slips forward on the sacrum. If the L4 is fractured, then it slips anteriorly on the L5 vertebrae. If the vertebrae continues to move out of position, it may then press on the spinal cord and the person may have neurological symptoms. When we look at mechanism of injury for this, typically what we see is a lot of hyperextension. This really predisposes the athlete to these two types of injuries. And athletes that have a lot of hyperextension typically have a lot of loading of the lumbar spine and the low back. So these include gymnastics, wrestling and football, especially linemen in football. Genetics as well as hereditary and just being born with their anatomical structure can actually be a predisposition for these injuries. Signs and symptoms: we may have muscle spasm in the area to help prevent any further damage, diffuse pain along the low back, radiating pain, burning, tingling, depending on how severe this injury is and how forward that part of the vertebral body has slipped forward. When we look at immediate care or treatment, we need to rest from any activity that's causing the low back pain, apply ice and elastic bandage for support, and typically this is something that we want to refer the athlete to a physician, and what the physician will do is look at non-surgical treatment first, doing rehabilitation, increase muscle strength in that area and decrease the pain. If that doesn't help, then they may go into surgery, and what they'll do is that they'll fuse the two bony parts together so to prevent it from slipping forward. For prevention, we want to make sure we have strong, flexible muscles around the core of the body and avoid continual hyperextension exercises that can predispose an athlete to this injury. Lastly, we have contusions. These are very similar to any other muscle contusion across the body, and they typically occur due to a direct blow. When we see a contusion on the spine, we see pain with motion, point tenderness, swelling, and ecchymosis. Also with muscle contusions, they cause spasm, stiffness, and inability to fully contract musculature of the spine. We look at immediate care. We want to make sure we apply ice, try to get those muscles to relax and to relieve some of the pain. Compress that area and rest. And if that doesn't work, we want to refer the athlete to a physician to see if there's anything else going on. Prevention, especially for football and other types of intense activities, we want to have them wear appropriate protective equipment, such as a brace or some other additional padding that the athlete can wear to protect the back area. So if you notice, I did skip over myofascial pain syndrome. It's not something that you'll typically see in your professions, but read over that real quick. It's just a small section on this first part of the chapter.